What are some diagnostic tests that need to get done with someone that has acute coronary syndrome? You're figuring out if they have an MI or not. An EKG. You imagine everybody gets an EKG as a welcome present to any ER or ICU ever. So EKG should always be on every patient. So you want to get in the habit of looking at EKGs just for that reason. But also it gets done to see if someone has an MI on their hands, worst case scenario, right? And come to find out, they're only 60% accurate. So it's just a little bit better than a coin flip, whether someone has ST changes or not. So we have to, again, look at the story, right? Not their whole life story, but the story leading up to the event, what happened. Oh, there's the same pain I had when I had MI 5 years ago. Oh, shoot. That's and you had to, but you don't have EKG changes. But let's do a what? A repeat EKG. So repeating it can be a way to see, to capture the MI. Okay. If they have NSTEMI, they're not going to have a STEMI, right? So they're going to have ST what? Depression, right? They're going to have what's called a TWE or a T-wave inversion. All right, so T-wave inversion, ST depression, those are signs of, that tell you might have an NSTEMI. And of course, STEMIs have ST elevations. And then pericarditis can have ST elevations as well. So it has diffuse ST elevations. It's not specific to one area of the heart or one area of the 12 lead. Like 2,3 AVF looks at the inferior wall of the heart. So if we just have ST elevation or ST depression there, that's probably a MI situation going on. But if it's ST depression or ST elevation throughout all the leads, that tells me that it's probably not a MI. That's something diffuse, right? It could be hypokalemia, can cause T-wave inversion, cause flattening of the T-wave. Hyperkalemia causes peaked T-waves. MIs have peaked T-waves also, but what's the difference? One is just lead specific, one is all the leads, right? Also whether it's narrow or not. Okay, so pericarditis has diffuse ST elevation. It also has AVR, ST depression. We'll talk about pericarditis. And chest x-ray. So chest x-ray, should it have a wide mediastinum? No, that's a sign of what? An aortic dissection. So that, it rules that out. Make sure it was not the worst case scenario, which is rare, right? A MI is much more common than aortic dissection, but we don't want to miss it. And also tells you, do we have a pneumothorax on our hands? Well, shoot, that's the reason why you have chest pain, right? Or they have a pneumonia on their hands. And yes, pneumonias, pneumothoraces can put stress on the heart. And yes, there are cases where it can lead to an MI, but we're looking at all the whole picture here, all these diagnostic tests. And a CTA of the chest, we talked about in pulmonary, that looks for a PE, right? Pulmonary embolism. So they're all the flow through all the lungs, and they say, whoa, shoot, they're losing flow in this one little area of your lungs. That is a PE. Okay, and it can also lights up the vessels of the heart and the vessels of the aorta, and you can see if there's aortic dissection or not. And then a coronary CT angio. That's usually done for stress tests. You're not going to really see those very common in the ICU. That's usually a more stable patient. You're trying to figure out, like someone that came with unstable angina. We're trying to see, is it really something going on, or is it something else that might be causing your chest pain or not? And then high sensitivity troponins. So these are a headache. They were rolled out like in 2018 or so, and they're still not done right to this day. So you're going to learn the right way to do it. So you have to advocate and see that we do get them done, because usually they just do one little high sensitivity troponin and they call it a day. But you're supposed to trend them, at least do two. You're supposed to get one now and one in 1 hour, or one now and one in 3 hours from then. It depends if they came through the ED or it's in the hospital. Like an RRT gets called to a floor and someone has a classic chest pain symptoms, we're going to do a troponin right then, and then we're going to do 1 in 3 hours to see if there's a change. Okay. So what is that change? We're really zooming in on the old troponin. The old troponin was 1,000 times less accurate, right? So a troponin, you've heard, it rises in like 4 to 6 hours. Like the classic troponin rises in 4 to 6 hours, goes away in 7 days. Well, now we're going to zoom in on that 4 to 6 hours there. We're going to zoom in right there, and we're going to look at this change in this slope right here. Is it going fast, or is it kind of a slow upstart? If it's slow, it probably might not be an MI. But if it's going rapidly, we can detect it immediately, and we also can see if it's the kind of the pattern that explains an MI or not. Okay, so what is that change? Again, it's kind of the jury's out, but basically, if you rise by about 20 points or so, that is concern, right? So they say a 20% change, a 50% change. We can just say 20 points. Troponin comes back at 40, and it comes back at 80. Well, that's a problem, right? Why is it going that fast? Why is it going 40 to 80 that fast, right? Usually, if you're more than 52, like in the ED, that's usually could be considered a coronary problem. So we have to look again. 1 hour later, did it change by 5 points? That is basically you're saying that they might have an MI in your hands. If it's greater than 120, no matter what, you have a 70% chance that it's an MI. So 120 is usually like the one you can consider. And back in the day, they used to be 1.2 troponin, right? Troponin greater than 1.2 was considerable that they might have an MI in their hands. Okay. If they're inpatient and they have chest pain, it's been less than 3 hours, we're going to do one now and one in an hour. If it rises by more than 7 points, right, that's considered a positive change. Okay. And if it's more than 15 points, whether you're female or male, definitely considerable that they might have an MI. Okay, so troponins, EKGs, chest x-rays, they might get a CT of the chest. All these things are looking to see if someone has an MI or not. And we're not talking about like once they have 12 lead changes, we're not going to like, oh, let's go to CT also. If they have an ST elevation, it's straight to CT, right? Sorry, straight to CT, straight to cath lab to get intervention done. But these are kind of like where it's dubious. We don't really know what's going on. We're going to do all these things to figure out what's happening. And then anybody that has any kind of sniff or any kind of inkling that there is something cardiac going on, what happens? You get an echo. You get an echo. Everybody gets an echo if there's anybody mentions there's some cardiac problems. Okay, so obviously if someone gets an echo and they have an MI, they're going to have a area of the heart that doesn't work good, right? If an area of the heart is, not getting perfusion, that area of the heart is not gonna move as much as it should, right? And if that area of the heart is dead, right, because it's completely infarcted, that's also going to make it so that area of the heart doesn't move as well, right? And do dead things move? No. So, but we can't say that area of the heart's dead on the echo. That's frowned upon. You got to say it's a wall motion abnormality. Well, yeah, that's abnormal because it's not moving, right? So you can see this echo right here. You can see this part of the heart is not moving at all because it's lost its flow. It's lost the perfusion. Okay. So a wall motion abnormality is what you're looking at on the echo. Usually when we hear echoes, we're always looking for an ejection fraction. That's important. I can tell you if the EF's 10% and they have wall motion abnormalities, but dang, they really got an insult to the heart, right? And you kind of ask them, hey, have you ever got this before? Do you have history of CHF? That could kind of clue us in, why they had developed the MI, because, we said CHF could lead to MIs as well. Okay, so wall motion abnormalities, they got valve disease. As we mentioned, what kind of valve disease can cause chest pain? Yeah, aortic stenosis being the most common. And then RV strain. We can look on the echo and we can see that the RV is like dilated or pushing into the left ventricle. There's things we can see to see if the heart is under strain, and that's the reason why the troponin is elevated, for instance. Okay, and if all this stuff's negative, then yeah, we can do a stress test, but usually this patient's not admitted to ICU, they'll be admitted to the floor. All right, and then any patient that has angiography, they have confirmed ACS, the best evidence is that we get a PCI done. We get a percutaneous coronary intervention done. All right, that's going to cath lab to see why they have these positive changes here. All right, so this little algorithm just informational. Usually, an X-ray can tell you if you have pneumonia or pneumothorax or not. It can tell you if you have a wide mediastinum, which tells you have aortic dissection. Is an X-ray going to show you have a PE? Pulmonary embolism? No, you have to get a CT angio at that point, right? So if you think that you have PE, the chest X-ray is normal, right? Then we get a CT pulmonary angio. We get to look to see, is there abnormal flow to the lungs, the vessels of the lungs? That's what maybe led to the rise of troponin, right? Or the reason why my echo showed this RV strain. Okay, EKG, again, only about 60% accurate, but it can tell you if you have ST elevation, where do we go? Straight to cath lab, right? That's the idea when you have ST elevation, straight to cath lab. So angiography right here. We're going to the cath lab, we're looking at their vessels, see if there's anything we can intervene upon. Is there any vessels we can open up and get better flow to? Otherwise, it might be pericarditis. As we said, there can be EKG changes with pericarditis, right? And we can, if it's not ST elevation, but it's ST depression, that could be an NSTEMI. And what are the values? It's usually about 0.5 in 2 or more leads is considered NSTEMI, like ST depression. And then for STEMI, we'll talk about, it's usually about 1 millimeter for the most part. But when you're in the precordial leads and the chest leads, it's like 1 in one lead and 2 in the other and 2.5 in another, depending if you're male or female. So it's a little bit foggy, but if you definitely have like more than 3 millimeters, for sure, doesn't matter where you are, ST elevation is ST elevation. And it has to be in the leads that look at the specific part of the heart, which we'll get into when we talk about 12 leads. All right, if that doesn't work, we have an NSTEMI. We're not going to cath lab right away. We're probably going to get some troponins, confirm our suspicions, see what's going on. High sensitive troponins are really where it's at. That's the most specific way to figure out if someone's having an MI acutely, if the heart is spilling troponins. Okay, if all that's negative, then yeah, we're going to be doing non-invasive tests. And of course, an echo is just for good measure. That's going to really let us know, give us some more information. Okay? So MI types. So there is, sometimes it's not always a MI, but it is damage to the heart, or there's other reasons why my troponin is elevating. Okay, so your troponin can elevate when you have a, obviously, for what we're talking about, when we have abnormal flow to the heart, the muscle cells of the heart don't get the oxygen they need. They start dying, going through apoptosis, and they start spilling all their stuff. And what's inside of heart muscle is troponins, right? Every muscle has troponins, right? It's part of the how muscles contract, right? And then other things in there can spill as well. We used to check what are called LDH levels, lactate dehydrogenase, which is used to form lactate. That's all cells have this enzyme. So we look, oh, the LDH is going up because it's spilling out of the heart. And lactate might go up a little bit, not significantly to like a sepsis situation, but lactate go up a little bit, but LDH definitely go up. Even when someone's white blood cell count might go up. Why would someone's white blood cell count go up if they have an MI? Repair. Repair, maybe good. So it's a stress response. Whenever the SNS fires off, it thinks worst case scenario, we might be under attack for an infection. So you have white blood cells that are just lining your arteries at all times. They're in the margins of the arteries, and whenever you have a stress response from the SNS, they demarginate. They come into the bloodstream, and it'll raise your white count to like 18, 20. If your white count is more than 20, it's definitely an infection. But if it's just like 18, it could just be reactive from a stress response. All right, so yeah, so type 1 MIs, that's our classic MI. They got a troponin elevation greater than 120. You're really thinking MI. But we're going to probably get some EKGs and echoes to confirm. If it's ST elevation, where are we going? Cath lab, straight to cath lab, right? The higher the troponin levels and you don't have other things going on, like they're not really a sick patient, they're really kind of thinking it's an MI that we have in our hands, right? Another thing to consider is like they come back from cath lab and the troponin is 10,000. It's like, well, that's not because they're having MI. They were in there manipulating things, opening flow, and troponins are spilling everywhere. So post PCI, you can have high troponin. That's perfectly fine. But we do trend them. Like if the troponin comes at 10,000, and then you do troponin in the morning after the next day after the PCI, and now it's 20,000. That's not okay. That's not what should happen. It should be going downward, right? You always want to find out what the peak troponin was, and it should be trending down after that. If it starts trending back up, that means you have another insult to the heart of some sort. So that's the classic MI with a troponin elevation, but other things can put stress on the heart, right? That cause the heart to get disturbed, right? So hypoxia can be one, right? Hypoxia via a clot that's in the way, or just hypoxia in general can cause my muscles to start breaking down. My muscle cells in my heart start breaking down, right? And then you can look at EKG changes, see if there might be a few wall motion abnormalities, but we're really looking to see, on coronaries, is there actual occlusion? If there's not, they can say it's what's called a type 2 MI, right? They have critical illness. They're in the ICU. That could be a reason why their troponin is elevated. They can have really bad pneumonia. This is causing reduction in oxygen delivery to my heart, and therefore my troponin went up because of that. Okay? And then sometimes there's just not an MI. It's not a lack of flow to my heart. It's my heart is upset for another reason. I have endocarditis. I have myocarditis. Pericarditis, right? Someone defibrillated me. Someone put electrical joules through my heart, and they caused my heart to restart outside of its normal cycle. Yeah, that's going to cause a rise in my troponins if you do cardioversion on someone, if you defibrillate someone. If someone does external CPR on my heart, is that because, was that because of MI? Maybe it's because of the CPR, right? But yes, someone can go down and need CPR when they have an MI. That's also true. But if someone has CPR because of like a pneumonia process or PE, for instance, that could be the reason why their troponins are elevated. A pulmonary embolism, as we mentioned, puts extra strain on the heart. The muscle cells have not died, that they are dying, right? They are getting stressed. And then critical illness, being admitted to the ICU, having be on the ventilator, these low oxygen states, these acidotic states put stress on the heart, and that can lead to a spillage of troponin, right? And there is overlap between these two, right? Demand and not an MI. There's a little bit of overlap there. So you'll see a lot of things that are on the same thing. It's like, well, why is it critical illness on both sides? Why is hypertension on both sides? So yeah, there is a little overlap there. But it's up to the cardiologist to kind of figure out what's, is this an MI I have in my hands? Do I need to take this patient to the cath lab or not? Or is this something that is expected from their ICU or from the illness? And we'll just trend the troponins, right? Make sure the troponins are going down. And you want to make sure they if they're greater than 120, we're really kind of considering an MI, right? We're up here, more than 120, we're considering MI. If they went to cath lab, is it going to be high or low? It's definitely going to be high, right? Well, other things up here in the high range, you can see like myocarditis definitely spills a lot of troponins comparatively. Okay, so you have type 1, it's usually spontaneous, right? They have a spontaneous chest pain, and it's usually you got your anginal symptoms, and it's usually an acute coronary syndrome. That's what's going on when we take it to the cath lab. Versus another one, what's not a MI, but it's something else caused troponin to be elevated. That's where you have like a sick patient, right? They have chronic diseases, right? It's usually a slower onset if they do have chest pain. It's a more slower development of this troponin rise. Okay, so type 1 is an actual MI. So type I is MIs. All right, so we're still talking about MIs and how they're treated. So how do you fix an MI? So the first thing we can do is give thrombolytics, right? Is it the best thing to do? No, the best thing to do is here in purple, percutaneous coronary intervention. That's the best thing to rapidly go in there and open up the vessel mechanically, right? We can also open up the flow mechanically by doing a bypass surgery where you take there's a little blockage right there. We're going to go past it and bypass it with a cabbage. But that's been kind of not phased out, but it's not the first thing we do. In the 80s and 70s and 60s and 50s, it was, right? They cracked open the chest within 6 hours, right? And that's what they did if you had ST elevation. But nowadays we'll take it to cath lab if we can. But what if there isn't a cath lab? What if you live in Ridgecrest, right? So you can't get to a cath lab immediately, right? So they have to in that ER. Of course, they're going to do a 12 lead. They're going to do an X-ray. They're going to do all the things, and they're going to say, oh shoot, we got a STEMI on our hands. So if they have a STEMI in their hands, they're going to say, hey, was this chest pain, less than 30 minutes, and did it happen, or did it happen? Has it been less than 12 hours, right? So the chest pain happened within 12 hours. These symptoms happen within 12 hours. Then it's okay to give our thrombolytics. So they're going to lyse the thrombus, all that clot that formed inside the vessel, causing the narrowing or causing the blockage of the flow to the myocardium. We're hopefully going to give a clot buster to bust the clots, right? So TPA is one, streptokinase is one. All you're doing is providing this enzyme that's going to activate plasmin. And what does plasmin do? Plasmin breaks down clots, right? It's a part of the natural coagulation cascade. Coagulation cascade makes clots and it breaks down clots. The back end of the coag cascade has the plasmin in it, which breaks down your clots and it turns it into little fibrin degradation products. Okay, so you need fibrinogen to make clots and then you break it down afterwards. All right, so that's your body's natural way to break down things. But when you make a clot, before that whole process happens, right? When you make a clot, you are going to stabilize it, right? When you make a clot in your body, it's like, oh, that's probably for a good reason. He probably got stabbed right now. That's this guy keeps getting stabbed, right? So then they're going to go ahead and cross-link the clot. They're going to make it stronger. And when does that happen? After 4.5 hours. That's why we give TPA or TNK within 4.5 hours, because it's not been cross-linked. It's not going to be effective after that point, okay? Especially in the brain, at least. In the coronaries, we got up to 12 hours to make that happen. Okay, so it's less than 12 hours, and we can't get them to a cath lab within 120 minutes or 2 hours. It's time to give thrombolytics, right? Which thrombolytic? Usually we lean towards alteplase. TNK, it can be given. We give it with CVAs now because it's easier to administer. And then sometimes there's streptokinase that we can give as well, which is made from bacteria. Bacteria are given the instructions to spit out proteins, and they grow them in a lab, and they spit out streptokinase. Okay, and that's going to do the natural thing to go into the body and cause a breakdown of the clot. Is that newer? Streptokinase is old. Yeah, it's not. Newer one is TNK. It's synthetic. Okay. What else? So, or you can go to get some bear urine and make urokinase. All right, but anyways, other uses for thrombolytics, we could get it acute PEs. So if someone has a pulmonary embolism, the TPA or TNK can be used. A lot of the data is for TPA. TNK is a little more new for PEs. But acute ischemic stroke, as we mentioned, is given for, that's another reason why we might give thrombolytics. All right, so what else? So what does it do? It's going to go in there, it would stimulate the natural process of breaking down clots by making more plasmin, and that's going to break down our clots. What are the side effects? It can break down clots in the brain. It can cause, if they're hypertensive afterwards, they're much higher risk of a intracranial hemorrhage, right? It also is a foreign substance, and it could cause angioedema, which is a serious life-threatening swelling of the upper airways. So that's something to keep track of when someone gets a thrombolytic of any sort, right? And of course, anaphylaxis, especially with the synthetic forms. All right. What else? Strep kinase may need higher doses if they have a recent strep infection, but so that's why usually we lean more towards TPA. All right, but within 2 hours, we're going to then, if hopefully we can, if they're, sorry, let's backtrack. If their symptoms don't go away, right, they're at Ridgecrest ER, they got their thrombolytics, and they still have ST changes, right? The ST elevation has not gone down significantly. They still have chest pain. Now they need to be flown to a center that does do PCI, that does do cath labs, and they can then investigate and open them up. Okay, so let's say, I think I have it on the next slide, over here, sorry. The PCI is needed if they have persistent symptoms or the ST elevation does not drop by 50% or more. Then they need to then go to a cath lab. All right, then the PCI. So if someone has a PCI, they come to the ER with all these symptoms of chest pain and such, and they have EKG findings, they have an echo finding, they have all the findings, then they go to, and they have ST elevation, I should say, then they're going directly to the cath lab, right? And the goal is 90 minutes, that's ACLS, right? Our times, I think, still are on 60 minutes right now. That's kind of what most hospitals in LA are, and it's like a little matchy game where they're trying to beat each other. We got 57 minutes, 30 seconds, look at us. So yeah, it's a whole thing, but the better, the sooner time you get to open up the vessel, the better outcomes there are as well. Okay, and you stent the culprit lesion. You're not going to go in there and like clean house and like put away and like they're going to open the RCA, open the obtuse marginal, open up the diagonal. Yeah, I saw you had a little 10% over there. I opened it up while I was there. It's not a thing. It's not like where you get a hysterectomy and a tummy tuck at the same time. All right, it's going to be they just do one side of the heart at a time. They don't do both sides because the risk of cardiogenic shock is very high if you do that. Also, there's a lot more contrast that's given, and there's a lot more debris that can be thrown around and cause problems, such as a stroke or renal insufficiency. It's best to do radial access if we can, right? It's much more well tolerated, less risk of hemorrhage and such. But an emergency STEMI, we're probably going to get that femoral access because a nice big vessel, we can easily landmark. And they get a stent placed. And what kind of stent? There's like 3 or 4 different stents out there. There's usually drug-eluting stents or bare metal stents. All right, drug-eluting stents are a little better because they prevent the formation of scar tissue. I used to think like drug-eluting stent is like secreting Plavix, but it's not. It's secreting like sirolimus, which is what your anti-rejection meds are made of, like tacrolimus, sirolimus. So they're getting this anti-rejection med basically that's being just eluted, being secreted from that stent over time. And they have better outcomes compared to bare metal stents. And there are some times where you would prefer bare metal stents, like if you know someone's not going to be taking their anticoagulants or antiplatelets, then they would they prefer to lean more towards bare metal stents. All right, so non-culprit lesions, again, we try to find the area of the heart that's dying right now, and then later if we found something, we'll go back and look at the other side. Usually it's before discharge, but or they depend on how they risk stratify. See, do they really need it right now, or can we do it later? Okay, so the risk of death is higher if they just did both sides of the heart at the same time. All right, so then if you can't do PCI, or sometimes they go in there and they look at the PCI and they realize, oh shoot, they got 3 vessel disease, or they got 2 vessel disease and diabetes, or they have left main disease, or the huge main artery coming off the aorta right there is like 90% stenosed. That's someone that probably needs a CABG. There are some cowboys out there, and we got 2 cowboys in our cath lab, and these guys, they will stent the left main. They will do that. They know it's high risk, but it's better than maybe getting open heart surgery, or maybe they don't meet criteria to get open heart surgery. So going there and stenting that can be an option. Okay, but if they have 3 vessel disease or they're unable to stent, then definitely we need to lead more towards a open heart surgery or CABG, right? And what do they say? They say with 3 vessel disease or diabetics. Remember, diabetics have glass vessels, and they are higher risk for coronary artery disease. So just 2 vessels, so let's say like 70% of the LAD and 90% of the RCA, they definitely need to get a CABG at that point. Okay. So yeah, proximal left main disease is probably a reason to do a CABG as well. We just go around the blockage. We take a normal vessel and we just we tear it off from the mammaries. So you don't need that anymore, and we're going to reattach it down past where the blockage is. We don't fix the blockage. We just bypass it, right? And it's not called bypass surgery because you bypassed it. That's why I thought for like 10 years. But no, it's called bypass surgery because the patient's put on bypass machine, right? So that's why it's called bypass. Either way, so getting someone that can't get PCI, or someone's been failed to treat medically, like they're not a PCI candidate, they were really, really sick, they have a lot of comorbidities, then a CABG can be used, right? And a CABG is actually better than a PCI. It actually has better outcomes, has less complications, not so much. Maybe after 30 days or so, if they don't have any problems, then yes, then a CABG is better. But you have your older patients, like in Vegas, a lot of people like to retire there. It's a hot CABG spot, right? All the 85-year-olds, 90-year-olds getting CABGs, right? Because you're really not a candidate for a PCI, and they got like 3 vessel disease, right? All right, if you have a PCI unavailable, you don't have it at your place, like in Ridgecrest, then they don't do open hearts at Ridgecrest, they don't have a PCI. But there's other places that don't do CABGs, right? So then they have to, don't do coronary intervention with through the cath lab. So then, yeah, back in the day, or if they don't have a cath lab, doing open heart is the way to go. I think it's like Bakersfield, they don't have a strong cath lab team, so they need to, but they have a very, very strong open heart program because of that. Okay, so yeah, so in STEM within 3 days or STEM within 6 hours, it's probably time to get that's another reason for getting open heart surgery. And I used to think that when they said, 50% occlusion, I used to think that, that was 50% all across the board, but it's not. It equates to it's a little quick way to convert. So if you say someone has like 67% stenosis, like that's not bad, 67%, 70%, that's not 100%, but that's 70% that they're seeing on the cath lab right here. So right here they see a little 70% blockage. That's equivalent to a 90% blockage. So when they look on the cath lab, they say, that's 50%. That's equivalent to a bigger blockage. You see if they have like 50% narrowing, that's equal to a 70% blockage. Yeah, so they're only looking in 2 dimensions. They're not actually looking down. So there's an equivalency there. All right, so that's how we can treat a MI, right? You can treat it with thrombolytics, you can treat it with a cath lab, or open heart surgery if cath lab fails or they're not a cath lab candidate.